We are here with Physician Pathways. My name is Natalie Yacobian. This is Aisha Mohan. We are M2 students who are here with Dr. Sutherell.
Yeah, so today we'll be interviewing Dr. Sutherell. Just to give you a little bit of background information about him, he went to medical school at the Medical College of Ohio. He did his residency at the Washington University in St. Louis in general pediatrics, did his fellowship at the University of Cincinnati Hospital in Pediatric Cardiology, and then his current job is the associate professor in the Division of Cardiology in the Department of Pediatrics, and he's also our associate dean of student affairs here at St. Louis University School of Medicine. So welcome, Dr. Sutherell.
Well, thanks for having me.
Of course.
So we wanted to start off and ask you, what drew you to pediatric cardiology?
So I will preface with saying my story is a little non-traditional.
Okay.
So I started college wanting to be an artist. And so Frank Netter was my hero. I was going to be a medical/scientific illustrator. So I started college with an interest in art, and I was on a music scholarship playing trumpet. And so pretty quickly I decided that I didn't want to be an artist anymore, and that I wanted to go to medical school and do more than just draw images, but actually help people. So decided to go to medical school instead. So with an art background and a music background then, meanwhile, summer breaks in college, I worked at a summer camp for kids, teaching kids how to rock climb and rappel and whitewater raft and all that kind of stuff. And so I had a background working with kids. So when I started medical school, I kind of had an idea that I would do something in pediatrics with that background, but I had no idea how the other pieces would fit together. As I went through medical school, what I found was that cardiovascular system, being so very visual with the visual arts background, it really resonated with me. And even beyond that, things like echocardiograms, reading ultrasounds of kids' hearts. What's an echo? It's just a moving image. I'm interpreting visual images, shades of gray, red and blue on a screen. And so for somebody with a visual arts background, that sort of went hand in hand. And then as a third-year medical student with a music background, the part of physical exam that clicked easiest was listening to heart sounds and listening to murmurs. My ears have been trained since elementary school to pick out different sounds. And so it all sort of made sense. Now, it makes perfect sense to tell that story and how the pieces fit together. And of course, there was no way that could put all of that together prospectively. But I remember going through anatomy and physiology, and it was paired with embryology as a first-year medical student, and going through cardiac embryology and learning about different heart defects and congenital heart disease, heart issues with kids, knowing I was going to do something in pediatrics. I think it was a single lecture that I had in my first year, but it just totally clicked and resonated. And I thought, this is so cool. It's with kids. It's visual. I can picture it. And then the pieces just sort of fell in place from there. So I started out with an art background and on a music scholarship and ended up as a pediatric cardiologist.
Oh, that's beautiful. Do you feel like your background in art, I know you kind of talked a little bit about like being able to hear the heart sounds and being able to kind of look at the echo. Do you feel like it's helped you connect with your patients as well and like explain things to them?
Yeah, so connecting with patients, in pediatrics, you don't just have one patient. You've got multiple patients. You've got the parents that you have to attend to every bit as much as the actual patient of the child that you're treating. And so how you explain information, you're explaining it on multiple levels. You're trying to explain it, if it's a 10-year-old, that 10-year-old needs to know about what their health issues are. But on the other hand, you're explaining it then to their 30-whatever-year-old parents. And you're having to adjust how you explain things on the fly to different levels, to different people, different patients. Let's put patients in quotes because I'm going to include the parents as the patients as well. My sort of bias as a very visual person is I'll draw out the heart for every patient that I'm explaining it to, and I'll give them a visual image of what their heart actually looks like, and I'll go through what normal anatomy is, and it's sort of on a very basic level, and then I'll draw where the hole is, or draw where the valve issue is, or whatever the heart issue may be, and go through that as a visual image. I don't know that I think patients appreciate that, and I've had patients that have told me down the road that 10 years later that we still have the picture that you drew for our little baby. And here's the 10-year-old now. And we showed it to them, and this is what their heart looked like. And I think patients appreciate that. But for me, it's being a very visual person, being able to draw out sort of on the fly of what the heart looks like and go through that with the family becomes pretty important and is a really important piece of how I'm going to connect with the families then.
I think that's wonderful. It's kind of, you have to be creative, but also you're kind of transcending the kind of didactic bridge that can often occur between
Absolutely.
physicians and patients.
Yep.
That's amazing. So another question that we had was, it sounds like you were pretty set from a very early age about what you wanted to do. I know a lot of people are still kind of deciding what they want to do, and that's really fine. But were you ever considering any other specialty, or was it always just pediatric cardiology?
Yeah, and now I'm going to put my student affairs hat on, because what I tell all third-year medical students is it's only your career. It's only the next, however 40 years of your life that you're making decisions on. And so you owe it to yourself to try every specialty on for science. You're going to rotate through the 7 core specialties over the course of your third year of medical school, and then have elective time in the 4th year. And you only owe it to yourself to even if everybody has an idea of what they want to do, maybe it's a fairly vague idea, but you owe it to yourself to try everything on for size. And so absolutely, my 3rd year of medical school, every rotation, okay, I'm on OBGYN. Could I see myself being an OBGYN? Absolutely not. I want to go over with the baby that's being warmed over there. So, okay, let's cross off OBGYN. But I tried it on for size to see how that fit. Can I see myself as being a surgeon? And so I went through my 3rd year trying every rotation on, knowing I'd probably end up in something in pediatrics, probably pediatric cardiology, even sort of at an early stage. But you owe it to yourself to try everything on for size. I knew, going into it, I had an idea it would be something with kids. I realized pretty quickly I like acuity. I like having to think quickly on my feet in acute situations, and nobody likes to be in the middle of a code situation. But I realized pretty quick that I was okay in those situations. I didn't sort of fear those, and so I knew that something with acuity would interest me. So I thought maybe pediatric surgery or even pediatric cardiothoracic surgery, because I see myself going that far. But at the end of the day, it ended up being pediatric cardiology, sort of roundabout confirmed what I was thinking at the beginning. But as a 3rd year medical student, you owe it to yourself to try everything on for size and to see what resonates.
Of course. Yeah, that's really good advice. I think it's something that a lot of students who have maybe no idea what they want to do, or maybe even do know what they want to do, just keep the same perspective of, the options are open and anything is possible.
Absolutely.
That's awesome.
It kind of sounds like you've kind of broken it down too, right? From like an initial interest to trying things out for size to finding something that clicks, and then lastly figuring out whether or not you want it to be acute or more like a slower pace.
Yeah, absolutely. And I think the one of the decision trees as you're trying to figure out your specialty is acuity versus not acuity. Do you want to be an ICU, ER, procedural-based specialty, or do you want to be more of an office-based, conversational, specialty? And the other piece of it is, do you want continuity? Do you want to have a cohort of patients that are your patients that you follow longitudinally over time? Versus I don't need that continuity. I like the acuity and I just want to deal with that. And so something like ER or something like ICU, adult or kids or whatever it may be. But those are, to me, sort of the two branch points as you're trying to figure out what you want to do. And for me, I knew that I wanted to do something with acuity, something that was procedurally based. But yet, on the other hand, I like that continuity. I love getting Christmas cards from my patients, and I love getting those family portraits. And I love, when I see long-term follow-up patients on their annual visits or whatever. And I love the fact that, they identify me as their doctor. And I love that long-term continuity that you're able to build. So I think those are sort of the two forks in the road of as you're trying to figure out your specialty: continuity versus I don't care about continuity, acuity versus not acuity.
That's really interesting. I had never thought about it in that way before. And Dr. Sutherell, I know you wear a lot of different hats and you do a lot of different things beyond just working in the clinic. Can you tell us a little bit about your journey through academic medicine?
Yeah, so as a medical student, I had no sort of thought towards academic medicine at all. I hadn't done a whole lot in the way of research in medical school. I knew I wanted to do pediatrics, and I thought pretty sure that I wanted to do pediatric cardiology, but how that unfolded and what that would turn into in terms of a career, I wasn't sure. I'm from Ohio, went to medical school in Ohio, came out to St. Louis for residency to St. Louis Children's Hospital, Washington University, and just like SLU, at the end of every year, the medical students give out teaching awards to faculty, and there's a teaching award that goes to a resident in the WashU system, a single resident that as the top teaching resident, and my intern year I won that. It's framed and on my it's still on my wall in my office, and it was this moment of, I never thought of myself as a teacher at all, but all of a sudden I got recognized for this, and what does this mean? And so then I started paying attention and thinking towards teaching. I mean, you don't go to medical school to be a teacher; you go to medical school to be a doctor. And so then I'm a senior resident running a team and paying a little more attention towards teaching. And towards the end of residency, I was offered a position as a chief resident, 3 chief residents per year, to stay for a 4th year of residency. At the expense then of delaying me starting my fellowship training, and I knew I was going into pediatric cardiology at that point. So I took the chief job, though, as I thought, well, this is my chance to try on teaching for size and see if it fits. I get to run morning report and teaching conferences with residents and sort of oversee on the administrative side of things the education of the residency program, and the rest is history. It obviously sunk in, and I took to it. And so in fellowship, so pediatric subspecialty fellowship training is 3 years long, during which you have to do an academic product, because most pediatric subspecialists, not all, but most pediatric subspecialists work in academic centers. And to work in an academic center, you have to do something academic. And so most people will do research during fellowship. I worked on a master's in education to get some, because nobody that goes to medical school has training in how to be a teacher. And course directors and these kinds of things are just people that have that over time develop, that have a reputation of being good teachers. But I thought, well, if I could get some formal training, that would sort of be something that I would have that a lot of people otherwise wouldn't have. And so what really resonated to me with education was with an art background. So now let's go back to the art background. So with a creative and music as well, those are creative arts. Mm-hmm. Pediatrics, you can't be that creative. I can be creative in how I approach a given child, of how they're melting down in mom's arms, and how am I going to approach this? You have to be a little creative, yeah. But on a day-to-day basis, where can I express my creativity? And I didn't find that in medicine. I actually found that in education. And so I think what really connected me to education then, and developing an academic side of my career in education, is that art background. Mm-hmm. Whereby I can express my creativity through how I teach and how I put together information in a creative way, package it so that, putting together lectures, putting together group discussions, those kinds of things, that's where the creativity can come out. And that's where, and so out of fellowship then, it just so happened as I came to SLU, back to St. Louis to SLU, the guy that was the PEDS clerkship director who ran the pediatrics rotation for Cardinal Glennon, was retiring. And so two years out of fellowship, then I took over as the clerkship director and did that for a number of years. And then an opening popped up in student affairs, and that's my role with you all now.
Wow, that's amazing.
So there you go.
Beautiful story.
I think you said something really important that I kind of heard when you were telling us the story. You had mentioned that you were kind of open during your residency to this thing that had never been on your radar before. Do you feel like that's an important part of as you're going through your journey, being kind of I know that it can be very hard as medical students. We feel like one thing and one thing only, but it seems like that was really important to your journey. I
would agree wholeheartedly, and connects back to previous parts of this conversation where, that you owe it to yourself when you're starting your clinical rotations to have an open mind and try out these rotations. The statistics, every student at SLU hears me say this, but the statistics are that the vast majority of medical students change their mind about what they want to go into from the time they matriculate to medical school to the time they actually match. It's published in Pediatrics that this was published maybe about 5 years ago, that they surveyed interns on day one of internship. Pediatrics is a 3-year residency program. Day one of internship. Okay, PEDS residents, what are you going to do in pediatrics? What's your practice going to look like? Same cohort, 36 months later, you're graduating residency. What are you subspecializing? Are you saying a general pediatrician? What are you going to do? The vast majority change their mind. And so it's critically important. We all have this mindset of, oh my gosh, I got to figure out what I'm going to do. I'd look at my friends and, oh, she knows what she's doing. But I don't know what I'm doing yet. I'm kind of freaking out here. We all have this mindset that we got to figure things out awfully quick. But the reality is you've got time and you got to be open-minded, because statistically, the vast majority of people change their mind at multiple steps along their training anyway. And so I think that having that, it's hard to sort of cast that aside when you've got somebody that she knows what she's going to do. Yeah. But having that open mind is critically important moving forward.
Definitely. So another question off of that is, because you wear all these different hats, how are you able to balance everything? And how do you feel that you're able to adjust work-life balance as well too?
Yeah, that's can I say work in progress?
Always a good answer.
That's an ongoing work in progress, and I think a lot of people that end up in administrative positions end up casting aside their clinical role. And so, but I'm too young for that. I spent too many years training to do what I do, to give up what I do. And especially as a medical subspecialist, there's a set of technology I do non-invasive imaging. And so echo, ultrasounds of kids' heart is what I do. And if I start giving up those kinds of things, or give up my on-call covering inpatient time where I'm helping manage post-op kids in the ICU and managing complicated arrhythmias, and if I start giving that stuff up for the administrative role, then those skills are going to atrophy, and I'm not ready to do that yet. But if I'm not ready to do that, that means that it's a true juggling act. And the other challenging aspect of it is medical student issues don't push pause when I happen to be in clinic or when I happen to be rounding on service, and likewise, patient issues don't push pause when I'm meeting with medical students, and so it's a juggling act, and it's something that I'm still working through, but it's a work in progress.
That sounds great. So, how do you prioritize your hobbies, things that you do outside of medicine, outside of academics, and stay true to what you like to do? Yeah,
I think that's critically important, and very, very important to me, and it should be very important to everybody. But for somebody that I didn't aspire to be a doctor since the time I was 5 years old. I had an initial career path that I was going on that was very different as a medical illustrator. And so, with these outside hobbies and outside sort of things that I do, that's who I am, and that's critically important to who I am. And if I lose the ability to foster those outside things, then I don't become Jamie Sutherell anymore. I become some other person, and I don't want to be some other person. I want to be me. So to me, it's a major priority. And unfortunately, the give and take, especially when you start having kids and other aspects of life start sort of factoring in. But to me, it's a part of what I have to do multiple times a week. And so if I end up getting my kids to bed and finishing up some work or whatever, and if it's 11 o'clock at night, sometimes it does eat into some sleep time, but I gotta go disconnect and go paint for a little bit because that's who I am. And so it's all about making compromises in your life of what email can wait till tomorrow. Do I take half an hour less sleep to be able to disconnect in the way that I need to disconnect? But that's the juggling act in the evenings for me. But that is critically important, and I have to do stuff like that to do things like painting, or to do things like the outdoors is where I sort of recharge. And so taking a weekend every once in a while to just disappear into the woods is as cliche as that may sound, is important to me.
Yeah, I agree with that. I feel like even though we're just medical students right now, that balance is super important. And just this 1 year in medical school has taught me, make time for yourself, your mental health, and things that are important to you should remain important to you, along the journey.
Yep. And the hope is, here we are coming out of this pandemic, and we talk a lot about mental health during the pandemic, and everybody doing things from home and Zoom, and all of a sudden the work-home boundaries are being blurred, and a lot of focus has been placed on maintaining these outside of work things in your, the things that make you who you are, the things that you enjoy doing. And my hope is that as we come out of the pandemic, that sticks, that focus on keeping things that are you, things that are important to you, sticks and continues forward. Yep.
That sounds great. You want to take the next
This is one of my favorite questions to ask, and we usually ask for only one, but since you wear so many hats, we'll ask for two. What are some of your favorite parts of your job, both as a clinician and as in academic medicine as well?
My favorite part of my clinical job is, so a lot of the heart defects that we treat need surgery, and that is the worst possible thing you can tell a parent, is that their beautiful baby, their beautiful child needs to have an operation. I'm not the surgeon. I'm not the one that actually does the fixing. I'll medically manage them up until that point. But my favorite part of my clinical job is their first post-op visit back with me. They're now discharged after a couple weeks, and they come back to see me for a quick post-op check, and just the stress that has melted away from the family of building up this monster of my kid has to have a major heart operation, and now here they are. They're like you think that the kid's not, well, we need to restrain the kid. They're recovering. We need to hold them back, but there's no way you can hold them back. And within days, the kid's like their normal selves. And Dr. Sutherell, what do I need to do he's bouncing off the walls. Is that bad? Is it going to hurt? No, just let the kid be the kid. The stress just melting away is fantastic. Yeah. And then I would say from the administrative educational hat, match day is the pinnacle of working with medical students, and the unbridled joy of seeing all of the medical students open up their envelopes when we do it in person, when we're not in a pandemic, and look and see where they're going. It is just ecstasy across the room. Everybody just ecstatic, and that is the highlight of medical school for sure. Full disclosure, we in student affairs we find out 24 hours earlier, so I know the answer of where everybody's going. Maybe I shouldn't give away that secret, but watching you all open up your envelopes is the pinnacle of the educational job.
Wow, that's amazing. Do you feel like there are things that are difficult in your job that you would, that even though it's hard and your job is obviously still worth it, but things that make the job a little bit more difficult?
Oh, there's no doubt. And I'll start with the clinical side. Not everybody can be fixed. Yeah. And I've been to more patient funerals than I want to. And these are kids. Yeah. And how hard is that to go to a kid's funeral and to watch the family grieving and or to give bad, a huge part of what I do is give bad news. Yeah. They come in for evaluation because of a heart murmur and they have this heart defect that's going to need an operation. That's bad news that I'm giving them. And so, as an intrinsically emotional person myself, creating emotion in others and having to manage that is extremely difficult. And then when you start having kids of your own, and then to try to leave that at work when I go home and I see my own kids that are the same age as some of the kids that are having bad outcomes that are not that becomes hard as well. So there's an emotional aspect of it that goes hand in hand with dealing with acuity. When you're dealing with acuity, when you're dealing with procedures, acuity goes bad. It doesn't always go well. Yeah. So that part of it is really hard. From a medical student standpoint, it's, sometimes students have their mind sort of fixed on one thing that they want to do, and for whatever reason, they're not able to do what they want to do. And so reframing and redirecting somebody who's been singularly focused on one career path for X number of years can be a challenge as well.
Oh, that makes a lot of sense. You can imagine like the double-edged sword of both, both the happy moments and the sad moments of both sides of your job.
Absolutely. And even match day, there's a lot of tears on match day, and I find myself looking, okay, are those happy tears or are those sad tears? I don't want to ask, but but yes.
Okay, so another thing that we wanted to know, and I think a lot of people would be interested in seeing, is what does a day in the life of a pediatric cardiologist look like, or a week in the life?
Yep. Yeah, so what I will say is that pediatric cardiology, it's a little hard to encapsulate, so I'll give a little bit of a summary just because of pediatric subspecialties anyway. Cardiology subspecializes quite a bit further, and so there's pediatric cardiologists that do cardiac catheterization, and they spend their days in the cath lab. That's not me. There's pediatric cardiologists that do electrophysiology, that deal with heart arrhythmias and spend their time in the cath lab zapping arrhythmias. That's not me. And so it varies a good bit depending on what your specific clinical niche is. I'm a non-invasive imager, meaning that I do echo. Most pediatric subspecialists work at academic centers, not all, but most pediatric subspecialists work at academic centers, meaning that there's an academic hat that you wear. So if I give an average sort of snapshot of a pediatric cardiologist, what they do, it would be about 4 clinical days a week, 1 non-clinical day, which is dedicated towards whatever research you might be doing or whatever administrative hat that you wear. And of the clinical days, several days of clinic, outpatient clinic, versus maybe in the cath lab for the other days, or the EP lab, or for me covering the echo lab. So every Thursday I cover the echo lab and read all the echoes for Cardinal Glennon Children's Hospital. But so 4 clinical days and 1 non-clinical day. Our group, we split call, and call is home call. where I would say probably 20% of the time I get called in the middle of the night to go deal with something, which is usually into the ICUs, either a post-op issue or a new baby that comes in that needs to be evaluated. But a lot of the pages at home are mommy calls, we call them, where, hi, my kid has this diagnosis and he started sneezing and what do I do with that? And those kinds of phone calls. But our group, we split weeks covering inpatient time as well, where now it's covering the cardiology patients on the floor, I'm the consultant in the ICU, managing the post-op kids, the consultant in the NICU, the neonatal intensive care unit, where all the babies will go before their operations, and rounding and doing consults and those kinds of things. So just varies. I would say on an average week, a pediatric cardiologist is going to work more than a general pediatrician, which probably translates to, on average, 55 to 60 hours a week. The inpatient weeks are quite a bit longer. And unfortunately, we don't have, once you get past your training, you don't have the 80-hour work week anymore, which we regularly would exceed that. But thankfully, those are just 1 week at a time. But I would say that's a normal sort of week.
Okay, sounds good. I think that gives a pretty holistic, snapshot of what it looks like. So another thing is that, because this field is very specific, do you see where it's headed in the future, or are there a lot of branch points for new trajectories? Yeah,
I think the single biggest, the future of pediatric cardiology is, let's take it to the adult side and the transition of care. 25, 30, 40 years ago, it was all just pediatric cardiology because kids with significant heart defects didn't live into adulthood. Now they're living into adulthood. And it's not just simple things like simple septal defects or just a hole in the heart. It's much more complicated things. Kids that have only one side of their heart that formed, where you can't restore normal, you sort of create a usable circulation. But these patients are now surviving in adulthood. And so adult congenital heart disease, I'm going to use, and maybe this is my bias shining through a little bit, but I'm going to use the phrase a public health crisis to describe adults with congenital heart disease, because who cares for them? Is it someone like me, a pediatric cardiologist? I'm not adult trained. I got 25 and 30-year-old patients that I follow, which makes me uncomfortable because I don't know how to screen for all the adult stuff. That's like way back to medical school to me. Like, I don't do that. But on the other hand, you pass these patients off to an adult cardiologist, that's not what they take care of, is complex structural heart disease. And so it's a population of patients that really and truly falls in the cracks. That is a real challenge to take care of. So that's the future of pediatric cardiology. The other side of it that's going to be the future is prevention. How do we prevent congenital heart disease from happening? And that's getting into the genetic and the more molecular basis of everything, of trying to prevent congenital heart disease from happening, which I suppose would work ourselves right out of a job if we were completely successful with that, but kids would be fine if we did. But that's the sort of the future. Wow. I never really thought about that. The transition of care is a huge thing that needs to be addressed. And those patients definitely deserve, the equal amount of care. And it's great that they're surviving, but we want them to live as long as possible. So, yep, that is great. So we've talked a little bit about your present and the future of cardiology, but we're going to take you back a little bit, back to med school one more time. If you could go back to med school, or if you could talk to all the incoming med students, what's one piece of advice you would give to them? I think can I say two? Yes, please. Yes. It's an easy one. We won't limit this. I think tying with previous conversation, though, I think keeping an open mind. Yeah. And I would say that, I'm going to make a number up, but I would say 75% of medical students are very focused on what it is they want to do and what they came to medical school wanting to do. But yet the vast majority are going to change their mind. And it results in a not insignificant psychological stress when all of a sudden, I was going to be a pediatric cardiologist. Oh, I loved OB. Oh my gosh, I never saw myself as an obstetrician. And, this frame shift. And so I think coming to medical school, starting medical school, especially when you get to the clinical rotations, with an open mind is so critically important. And the other thing that I think that hits medical students hard is you feel like I got to pad my CV nonstop. Yeah. And so the tendency for medical students is to get involved in as many different organizations as they can and do as many different things as they can. And all of a sudden their grades start suffering and they're miserable. And now they got the CV with 50 things on it, but I spend an hour here and half an hour here. And the other piece of advice I would give, it would be just to, rather than do all these different things, focus on things that you're passionate about, focus on things that you're interested in, really engage in those, maybe a few things to a deeper degree than trying to do 100 different things. Yeah. I think that's really good. I think that's advice that we all need to hear. I hear it all the time that we all feel that mad rush or that mad kind of
fear that our CVs aren't padded enough.
Absolutely.
I think that that's really, really good advice.
It's a false mad rush.
Yes, you're right.
Sounds good. So thank you so much for joining us. We really appreciate you taking time to be interviewed by us. Was there anything else you wanted to add?
No, just thank you so much. I feel like, every time we've heard you talk and lecture, we've had the pleasure of, having you kind of guide us through as our dean as well. So thank you again for taking even more time to
Of course.
help us. And we love
Thanks
it.
for having me. This was fun.
Of course. Thank you so much.
Sure.